So we're going to talk about cardiac output and venous return curves. And I think it's fair to say that many medical students have studied cardiac output and venous return curves and never quite understood what they're good for once they go off and get in the clinic. So maybe they're just something for studying for boards or passing a physiology test. Hopefully, what we're going to do is unravel cardiac output and venous return curves and let you know how they tell you about what the heart does and how it interacts with what the blood vessels do. So, cardiac output curves tell us about the heart, and venous return curves tell us about the blood vessels. And that pair of curves tell us about how the heart and the blood vessels interact with each other to understand two things that we measure clinically: cardiac output, which we can measure by thermal dilution or using echo and Doppler techniques, and central venous pressure, which is equivalent to right atrial pressure. So let's take a look at what our agenda is, and let's get started. We're going to start out looking at the model of the heart and blood vessels, the circulation that we're going to use for cardiac output and venous return curves, and identify the critical pieces for the axes on cardiac output and venous return curves with the various names and important points that you should be able to recognize no matter what the intervention is. We're then going to move on and talk about the cardiac output curve and very specifically how that tells us about heart function. And then we're going to talk about the mean systemic filling pressure and the resistance to venous return curve as they define the venous return curve. And we'll talk about each of those two components so that you have a physical understanding of what they mean from a functional point of view. We'll then review the three questions that we ask every time there's an intervention that can change cardiac output and venous return curves, and talk about how interventions change the intersection point by looking sort of at theoretical changes in intersection point that can help us tie these curves back to central venous pressure and cardiac output that you might measure in the clinic. And then as a final item, we'll look at two addenda where we talk about what happens if mean systemic filling pressure and resistance to venous return fight each other during these interventions, and how do you deal with the fact that some interventions are extremely complex and change with time, so that the initial intervention does something and then there's some homeostatic adjustments that happen thereafter. So that's quite a bit to talk about. Let's get going. First on our agenda is to look at the model of the circulation as it relates to cardiac output and venous return curves. And what we see is that we have the right atria and the right ventricle going into the pulmonary circulation, coming into the left atrium and left ventricle. Then the blood goes out into the aorta, goes to all the systemic circulations, and then returns back through the veins to the right atrium again. So it's a whole circulation. And from the point of view of cardiac output and venous return curves, we're going to sort of assume everything above the dotted line is heart. So that's the right heart, the left heart, and the lungs. And the systemic vasculature is related to what happens with venous return curves. So everything below the dotted line is going to be related to the systemic vasculature. And so the heart is a little bit of not just the heart. Mostly we're going to think of it as the left heart, but it does include some things that happen to the lungs. Then what we have to do is figure out what's cardiac output and what is venous return. And what you see is, because this is a circulation, whatever comes out here ultimately has to come back here, or everything will end up in the above the line or below the line. And so what we know is that the theory here is we're dealing with a steady state where cardiac output is equal to venous return. And the normal textbook value at rest is 5 liters a minute of cardiac output or venous return. And so they're sort of synonymous for each other. So why do we talk about both of them? Well, to understand that, what we have to understand is that we're going to think about this part as sort of being a pump, okay, that pumps things in here into the circulation. And so as you speed up the pump, what's going to happen is the pressure on the outflow side of the pump here is going to rise, and the pressure on the inflow side of the pump here is going to fall. So the more we turn the pump up, the higher this pressure is going to get, and the lower this pressure is going to get. So what happens if you turn the pump off? And the answer is, if you turn the pump off, then the pressure everywhere will be the same throughout the circulation, and we call that, or define that, as mean systemic filling pressure, and the textbook value for mean systemic filling pressure is 7 millimeters of mercury. So that's the pressure that would exist if the heart were to stop and we allowed the pressure in the arteries and the veins to come to equilibrium with each other. And we'll talk a little bit more about why the number is 7 when we talk about mean systemic filling pressure. But for now, what we're going to do for the point of view of our model is say that no matter how fast the pump is moving, there's a point in our circulation where the pressure is always 7 millimeters of mercury. And the pressure is higher on this side of it, and it's lower on this side of that point in the circulation. And that's probably in the small venules. And so it doesn't matter how fast blood flow is going. That pressure is always 7 millimeters of mercury. And the reason that's conceptually important is because the flow going up until that point in the systemic circulation, we're going to call cardiac output, and the flow anywhere downstream from that circulation, we're going to call venous return. And we notice that both of those are going to be, on average, in a normal resting person, 5 millimeters of mercury. But we're going to call it cardiac output when we're on this side. And we're going to call it venous return. Whoops. Pardon me. We're going to call it venous return when we're over here. So it's arbitrary, and one of the jokes I tell is, how far can a bear run into the woods? Halfway, because then he's running out, okay? So you're running into the woods until you get halfway into the woods, and then you're running out of the woods for the rest of the trip. And it's sort of the same arbitrary definition of cardiac output and venous return. And again, we're going to talk a little bit more about that, but we want to recognize that this 7 millimeters of mercury, no matter how fast the cardiac output goes, exists in the small veins. So let's take a look at the standard normal cardiac output and venous return curve. And what we note is that the x-axis is right atrial pressure, so that's measured in millimeters of mercury, and the y-axis is cardiac output, and so that has units of flow, liters per minute. So the y-axis flow and the x-axis millimeters of mercury. And we see two curves on here. We see this curve here. Whoops. I think I'll actually write over that curve there. This curve here is the cardiac output curve. And this curve here, whoops, this curve here is the venous return curve. And we can measure each of those. And the first thing to note about each of these curves is that the black curve is all about the performance or the function of the heart, and the red curve, the venous return curve, is all about the function of the blood vessels. Okay, so we're going to look at it from that point of view as we go forward here. There's some other points that we want to recognize on this curve, and one of them that I want to point out right to start with is this point right here where the venous return curve hits the axes. And what we notice about that is that this is the point at which the cardiac output is zero. So this is the right atrial pressure axis, and the right atrial pressure when cardiac output is equal to 0 is where this purple dot is, and we're going to call that mean systemic filling pressure, PMS. Sometimes we call it systemic filling pressure, so you see both kinds of abbreviations. But the question is, what does it represent? And the answer is it represents the pressure in the circulation when cardiac output is 0. So if we were to stop the heart and let the blood pressure in the arteries fall and the blood pressure in the veins rise, they would be equal in the arteries and the veins to 7 millimeters of mercury. And we'll talk a little bit about why 7 millimeters of mercury and why the arterial pressure falls more than the venous pressure rises when we talk about mean systemic filling pressure. But how did we know it was 7 millimeters of mercury? We looked at the value on the right atrial pressure axis. So what is right atrial pressure equal? Because the pressure everywhere in the circulation is mean systemic filling pressure when the flow is 0. Okay, and so the typical textbook value of mean systemic filling pressure is 7 millimeters of mercury. The other critical point that we have to pick off on these curves, and labeled N here for normal, is the point at which the cardiac output curve intersects with the venous return curve. And that point is the only point along the cardiac output curve that you're actually operating at. And the only point along the venous return curve that you are actually operating at. So this is a bunch of potential points you could operate at, but you're only operating at this point. This is a bunch of potential points the heart could operate at, but it's only operating at this point. And so what we know is the heart and the blood vessels where they cross each other represent the actual operating point. And we can take this intersection point here, and we can look at what the actual values are. And what we see is that the right atrial pressure is very near to atmospheric pressure, or 0 millimeters of mercury in a textbook value for a normal heart. And that the cardiac output is very near to 5 liters per minute in a normal resting heart. So cardiac output normally about 5 liters a minute. Venous return normally about atmospheric or 0 millimeters of mercury, because atmospheric pressure is our reference point. So whenever you look at these curves, pick out this point and pick out this point. And this one is the mean systemic filling pressure, and this is the operating point. Very important points to pick out. Now let's take a look at the cardiac output curve per se and think a little bit more about what it is actually showing us. And so again, as a reminder, the x-axis is right atrial pressure, so that's the forcing variable or the independent variable, and the dependent variable is cardiac output, how much blood flow you get. And what the curve tells us is as you increase right atrial pressure, as you move to the right along the curve, the cardiac output rises and rises and rises, at least up until some point where it may top out. So increases in right atrial pressure cause increases in cardiac output. Why is that? And the answer is because right atrial pressure, looking back at our model here, right atrial pressure is determined by how much flow is coming back here, which determines how much flow goes into the pulmonary circulation, which determines how much flow comes back here. And ultimately, right atrial pressure ends up being related to the end diastolic fiber stretch of the fibers in the left ventricle. So you'll recall end diastolic fiber stretch, uh, uh, which is measured either as end diastolic volume or end diastolic pressure, are all terms we use to associate with preload. And you'll remember preload speaks to the idea that what we can do is get optimal sarcomere overlap. So here's our myosin with its myosin heads, and the little square thing there are the actins, the thin filaments. And as we stretch sarcomeres, what we can get is better overlap between the myosin heads and the active sites on actin and get better performance. So there is a law of the heart called Starling's law of the heart, which we discussed in pressure volume loops, among other places, which tells us that increases in preload go to increases in stroke volume. And just to remind you, there's a direct relationship between stroke volume and cardiac output, because cardiac output is stroke volume multiplied by heart rate. So if you increase stroke volume, you're going to increase cardiac output. So basically, if we look at a cardiac output curve, it's an expression of Starling's law. Okay, the more preload that we have, which we are measuring now by right atrial pressure, the greater the cardiac output that we get. That's Starling's law of the heart. So we've shown this initial relationship between cardiac output and preload as a cardiac output curve. But the question is there only a single cardiac output curve? And the answer is no. We actually can get changes in the cardiac output curve, and so it can move up and to the left, in which case we say the heart is hyper effective. Okay, and what are we saying here? What we're saying is for a given change in preload, right atrial pressure, we're getting a rather larger change in than we did when we were looking at this blue curve here. Whoops, I'm sorry. This blue curve here. So we have sort of the same change in preload, but what we get is a much smaller in the normal effective heart, a much smaller increase in cardiac output. And we can have a third condition here where the curve looks like this, which we call a hypoeffective heart. And what we see there is for the same change in preload, right atrial pressure, we get an even smaller yet change in cardiac output in a hypoeffective heart. So this is a tiny little up arrow, and the blue one is a slightly bigger up arrow, and the red one is the biggest up arrow of all. And so what we can think of is that the cardiac output is an expression of the gain of Starling's law of the heart. Hypereffective hearts, the gain, the amount of cardiac output you get for a given change in preload is elevated. And in a hypoeffective heart, the amount of increase in cardiac output you get for a given change in preload is depressed. What are things that can increase the gain? The most quick one that should come to mind is inotropic state or contractility. So if you increase contractility, for example, stimulating the beta 1 receptors with the sympathetic nerves, Starling's law is going to work more effectively than if you withdraw sympathetic tone from the beta 1 receptors, in which case Starling's law is going to work less effectively than normal. But there are other things that can cause a hypoeffective heart, such as ischemia and myocardial infarcts, loss of proper muscle functioning in myopathies, constriction of the heart's environment by cardiac tamponade, and so forth and so on. So, what we're interested in with all these things is what affects the heart muscle cells itself and the ability of Starling's law to express itself. So, with that, let's move on and look at the vasculature just a little bit. So when we think about the blood vessels, we have to think about two things. One is the mean systemic filling pressure, and the other is the resistance to venous return. And you'll remember that we said mean systemic filling pressure is identified on a venous return curve as the point at which, or the right atrial pressure at which the cardiac output is zero. And so the typical textbook value for mean systemic filling pressure is equal to 7 millimeters of mercury. Now, if you think about the arterial side of the circulation, and the pressure in the arterial side of the circulation, so we're going to display it as a hydrostatic pressure here. We know that a typical, say, mean aortic or arterial pressure is about 100 millimeters of mercury or so. On the other hand, if we look at the venous side of the circulation, we find out that the pressure of the right atrium is about 0 millimeters of mercury, which we conclude is atmospheric. And so the arteries and the veins are usually connected to each other by a thing. And what is usually happening is the heart, which is a pump, is pumping fluid from here and putting it in here. And so it's sucking it out of the venous side and putting it into the arterial side. And so the venous pressure is notably less than the arterial pressure. Well, what we said happens if you suddenly stop the circulation is the pressure everywhere goes to 7 millimeters of mercury, which is our mean systemic filling pressure. And this little diagram here gives us some insight to why that is so. What you see is that the hydrostatic height on the venous side increases very little in comparison to the decrease in pressure in the arterial side, because you can accommodate this volume that is now sort of coming out of the arterial side of the circulation very easily in the much more compliant veins. So the reason that the vein pressure only increases a little and the arterial pressure falls a lot is because the veins are much more compliant than the arteries. And so the average of the arteries and the veins is about 7 millimeters of mercury when the blood is distributed in such a way that the pressure everywhere is equal. And that's when the pump gets turned off. That is, the heart is no longer beating. So that's the mean systemic filling pressure. And again, we see the 7 millimeters of mercury showing up here when the flow is 0 on our venous return curve. And we have some insight that that is related to the compliance of the vessel. So what are the things that might increase mean systemic filling pressure to some value above 7? Okay, so if we turned off the heart. And so what you can see is that if you put more fluid into the circulation, meaning more blood into the blood vessels, so fluid means blood when we think about it this way, you'll see that we are going to increase the mean systemic filling pressure. But what's the other way that we could increase mean systemic filling pressure? And the answer is we could make the two containers more narrow than they are. And so now all the volume over here has to be moved over to here, and all the volume from here has to be moved over to here. But we're going to end up once again with an increase in the mean systemic filling pressure. So the other thing that can increase mean systemic filling pressure is a decrease in container size. And when we think about the container is the size of the blood vessels, so the amount of lumen capacity, and we see that the compliant side of the circulation is really the veins. And so we're going to think about the size of the venous compartment as being the most important here, although the arteries also play a role as well. So now we can think about the things that affect mean systemic filling pressure as being the blood volume that you have in a patient relative to the size of the blood vessels. Blood vessels. And there are two ways to increase mean systemic filling pressure. One of them is to increase the amount of volume in the patient. And the other, because you're dividing by a smaller number, is to decrease the size of the blood vessels. Both of those will tend to increase mean systemic filling pressure. And conversely, mean systemic filling pressure will decrease if you lose blood volume or if you increase the size of the veins. So the main thing that determines size of the veins, okay, is the fact that the veins have alpha 1 receptors on them. And if the alpha 1 receptors are stimulated by sympathetic, they cause constriction of the blood vessels. And if you remove sympathetic tone, you get dilation of the blood vessels. So sympathetic, constricting blood vessels increase mean systemic filling pressure, and systemic vesicles withdrawal sympathetic tone causes the blood vessels to get bigger. Alternatively, you could give a transfusion, which would actually physically increase the blood volume, or you could hemorrhage out or become dehydrated through sweating, and that would decrease blood volume. So we have some intuition about what increases and decreases mean systemic filling pressure. If we increase mean systemic filling pressure, we're going to just show the curve, the dot on our curve, the pressure at which cardiac output is 0 would move to the right. And if we decrease mean systemic filling pressure, where we draw our dot will move to the left. So that gives us some idea. And if nothing happens, but we change the position of the dot, the rest of the cardiac output curve will follow along the same path as before and move parallel to the original curve, whether we increase or decrease mean systemic filling pressure. And you're not going to worry about it, but where this turns off and plateaus, it's going to be the same for each of the curves. It's going to occur at the same pressure, -3 And that's really determined by the fact that interthoracic pressure is -3. I'm not going to spend a lot of time talking more about that. So we know if only mean systemic filling pressure changes, we're going to shift the curve parallel and to the right or parallel and to the left if it decreases. And we are going to think about it as being related to the position of these points here, because it's going to turn out that resistance is going to change the slope of these curves. So let's talk about how resistance affects venous return curves. And so starting clean with a new venous return curve, let's take a look at the resistance to venous return curve. And just for reference again, here was our mean systemic filling pressure when the cardiac output is 0. It's the pressure that is going to be in the right atrium when there is no flow in the circulatory system. So just to remind you about venous return is a flow, you'll remember, and we can use our triangle here where we write P for pressure, Q for flow, R alphabetical order, and we can cover up the one that we are interested in to solve for the others. And so because venous return is a flow, we cover up the Q, and we see that it's related to the pressure drop that drives the flow divided by the resistance to venous return that we see in the vascular segment. And another just quick reminder here about the anatomy and what we're talking about when we're talking about venous return is we're talking about the part of the circulation from some part in the venules here where the mean systemic filling pressure is 7 millimeters of mercury, down to the right atrium where the normal right atrial pressure is 0. So we're talking about flow through this segment when we're talking about venous return. And so let's try and put that notion onto the diagram here. And so we're going to cover up our flow, and we need a pressure drop over a resistance that drives venous return. So venous return is equal to the pressure head driving return. So the upstream pressure is mean systemic filling pressure, and the downstream pressure is right atrial pressure, and the resistance is the resistance to venous return, which is basically the resistance of this segment. Now, it's a little bit confusing. This is a model, but even though we're talking about resistance to venous return, it turns out that the resistance to venous return depends on the resistance both of the arteries and the veins. And who are the resistance vessels? It's the arteries. So in terms of resistance, what you can think about is sort of the caliber of the arteries, if you will, as determining resistance to venous return. So we said mean systemic filling pressure, think about the size of the veins, the capacitance vessels, and resistance to venous return, think about the size of the arteries and the arterioles specifically in terms of the slope of these things. So before we go further with this, so this is a flow, remember, that we're looking at here, and it's a pressure drop divided by a resistance. So let's take a look at the pressure drop relative to the venous return curve. And so let's start by saying, okay, let's put a right atrial pressure of about 4. What is the pressure head driving flow back to the heart? It's the upstream pressure, the PMS, minus the right atrial pressure. And the slope of the line is the resistance. But we can read off
the flow here, and it's going to be about 2 where I drew the dot. Let's pick another right atrial pressure that's a little bit lower. Okay, what's the pressure head driving flow back to the heart now? It's this blue difference, PMS minus PRA. And notice what that does, because it's a bigger difference, because we've decreased right atrial pressure when we did the blue line, we get an increase in venous return. Let's draw yet another one. So let's draw a dot here. And now what we see is that the difference between mean systemic filling pressure and right atrial pressure is even bigger yet, because we've got an even bigger decrease in right atrial pressure. So we get an even bigger increase in venous return. And if we look over at the cardiac output axis, you see indeed it does increase. And then finally, back to our normal right atrial pressure of 0, we see we have this difference here. And so we get an even bigger yet venous return, because we have an even bigger yet decrease in right atrial pressure, making this difference bigger. Because all along, the mean systemic filling pressure stayed fixed at 7 millimeters of mercury. So we're assuming nothing changed except right atrial pressure. Okay, we'll come back to what changed right atrial pressure again in just a moment. But what we can see is that the slope of the line is going to be related to resistance, the resistance of venous return. So starting with a clean venous return curve again, let's consider how it is that when we have a mean systemic filling pressure here, and let me actually put the mean systemic filling pressure pinpoint on here. How is it that we decide which point right atrial, who is it that decides which point right atrial pressure is working on the venous return curve? And the simple answer to that is it is cardiac function. So if you have a very hypoeffective heart, it crosses here. If you have a slightly better heart, it may cross here. Slightly better heart, it may cross here. A normal heart, it may cross here. A hypereffective heart, it may cross here. So that the more effective the heart is, what happens is the lower the right atrial pressure that you intersect the venous return curve, and therefore the bigger the difference between mean systemic filling pressure and right atrial pressure. So this gradient, PMS minus PRA, is proportional to the effectiveness of the heart. And that's how the heart does what it does. The more effective it is, the more it decreases right atrial pressure and intersects this curve. So our operating point, as we said earlier, is always where the cardiac output curve intersects the venous return curve. Starting fresh, we can look at what happens if the slope of the venous return curve changes. So one thing that could happen is the slope of the venous return curve could become more shallow. And the other thing that could happen is the slope of the venous return curve, or the resistance to venous return curve, could become steeper. And now we have to figure out whether a steeper curve is an increase or a decrease in resistance. And again, using our triangle, B, Q, R, this time we're interested in this time we're interested in resistance. So we're going to do a pressure drop over a flow. And so let me just write that explicitly. Resistance to venous return is equal to Tm minus T or A over venous return or cardiac output. And what we want to look at here is whether this slope is representing a pressure drop over a flow or a flow over a pressure drop. And so remember, it's delta y over delta x when you look at the slope of a line. And so y is a flow and x is a pressure here. So what we see is not pressure over flow, it's flow over pressure. So the slopes of these lines are conductances. So the violet line here represents an increase in conductance. We usually use it for conductance, which means it represents a decrease in resistance. And the red line represents a decrease in conductance or an increase in resistance. So counterclockwise is increased resistance, and clockwise represents a decrease in resistance. What are some of the things that are going to change resistance? And again, what I said is think about the arteriolar side. So alpha 1 activation causes an increase in resistance, for example. So sympathetic tone to the arterioles will increase resistance. You can get a decrease in resistance if you have an AV, an arterial-venous fistula, because basically that is adding another pathway in parallel. Whenever you add a pathway in parallel, you decrease the total resistance. You can work that out for yourself. Another thing that can happen is that you can get massive vasodilation in some kinds of diseases, and you go to a venous return curve that looks like the purple one.
So when it comes to actually trying to figure out how an intervention affects the cardiac output and venous return curves, we always want to ask the same three questions in the same order. And the first question is, does the intervention change the cardiac output curve? And remember, we're saying cardiac output curve, not cardiac output. And what we're really asking is, does it change the gain of Starling's law of the heart? That is, does it make it a hyper-effective heart, in which case we shift the curve up and to the left, or does it make a hypo-effective heart, in which case we shift the curve, the cardiac output curve, down and to the right? The second question we want to ask is, does the intervention change the mean systemic filling pressure? And here we're asking, does it change the blood volume relative to vascular size? If it increases the volume in the container, the blood volume relative to container size, so an increase in blood volume or a decrease in container size, we're going to get an increase in mean systemic filling pressure. And if it decreases the blood volume or it increases the container size, we're going to get a decrease in mean systemic filling pressure. And the final third question that we ask is, does the intervention change the resistance to venous return? And here we want to really think about total peripheral resistance in the arterioles, which are the resistance vessels. And if it increases total peripheral resistance, we're going to pivot the curve in a counterclockwise direction, more parallel to the pressure axis. And if it decreases resistance to venous return, total peripheral resistance, we're going to rotate the venous return curve clockwise, more parallel to the cardiac output or venous return axis, which is a flow axis. So increased resistance counterclockwise, decreased resistance clockwise. Always these three questions, same order, every intervention. And remember, sometimes the answer can be it doesn't change it either upwards or downwards for each of the three questions.
So now that we know the three questions, let's do a couple quick examples just to get the idea. In the first example, we're going to give a pure inotropic agent. So I don't know if any such thing exists in real life, but for their purposes, what does an inotropic agent do? It increases the performance or contractility of the heart. So what's it going to do to the cardiac output curve? It's going to shift the cardiac output curve up and to the left. So that was question one. Question two, what does a pure inotrope do to the volume in the container relative to container size, i.e. mean systemic filling pressure? And the answer is mean systemic filling pressure is not going to change because an inotropic agent doesn't have any effect on blood vessels, and deep systemic filling pressure is a blood vessel thing. And the third question is what does it do to resistance to venous return? And the answer to that likewise is nothing because, again, a pure inotrope does nothing to blood vessels. So where's our new operating point? It's right here. What happened to right atrial pressure? It went from there down to there. And what happened to cardiac output? It went up to here. And so what we saw is that a pure inotrope increases cardiac output and decreases right atrial pressure. So let's try again. This time giving a transfusion. What does a transfusion do to the cardiac output curve? Does it change Starling's law of the heart? No, the gain of Starling's law stays exactly the same because the transfusion is doing something to the blood vessels, not to the heart. And so the new cardiac output curve is right on top of the old cardiac output curve. What does a transfusion do to mean systemic filling pressure? And it's an increase in volume with essentially the same size container. So the volume relative to container size is going to be at a higher spot than it was originally. So let me draw the original one here. And so the new one is to the right side here. And then the final question is, what does it do to arteriolar tone, to total peripheral resistance? And it doesn't do anything to total peripheral resistance. So we're going to draw our new venous return curve, virtually parallel to our original venous return curve. And our new operating point is going to be, our new intersection point is going to be here. And so what we see is that, let's throw the originals in. What we see is that we got an increase in cardiac output and an increase in right atrial pressure, central venous pressure, when we gave the patient a transfusion. Let's do a third one, and this is an AV fistula. And the first thing that we ask about is what does an AV fistula do to the gain of Starling's law of the heart to the cardiac output curve? And an AV fistula is a hole between an artery and a vein, which has a relatively large resistance in parallel, if you will, which is going to decrease the total peripheral resistance. So that's all about blood vessels and not about hearts. So where's our new cardiac output curve? Right on top of the original cardiac output curve. What does it do to the volume in the container relative to container size? Well, we didn't put blood in or take blood out, so there's the same volume of blood in there. How about the venous container size? And an AV fistula, relative to the 5 liters or so of blood we have in the body, occupies negligible volume. So the volume in the container relative to container size is going to be right on top of where it was originally. So we draw our dot right where the original dot was with no change in mean systemic filling pressure. And finally, we said adding a resistance in parallel decreases the total resistance. So which way do we draw the curve? Clockwise or counterclockwise? That's right. Counterclockwise is a decrease in resistance. So we draw the curve up and to the right. And so our new venous return curve looks like this with the decrease in total peripheral resistance. And the original was here and here, and the new one is here. And so what we see is that we got an increase in right atrial pressure and an increase in cardiac output. So each of the interventions we've done so far has only affected one thing on the curve, but that's not always true. So our last intervention is a change in sympathetic tone, and this is a complex intervention that ends up affecting more than just one thing, unlike the other three, which have affected just one aspect of the cardiac output and venous return curves. And the first question always is, what does it do to the cardiac function curve? And the answer is because there's beta receptors that are stimulated by the sympathetic, we're going to get an increase in inotropic state or contractility. And that's going to shift our cardiac output curve up and to the right. The second question is, what happens to the volume in the container relative to container size? And we didn't change the blood volume, but we have alpha-1 receptors on the capacitance vessels, the veins, and they're going to constrict when you get an increase in sympathetic tone, which makes the container smaller. So the volume in the container relative to container size went up, same volume but a smaller container, and so the mean systemic filling pressure is going to rise. Now, resistance to venous return, we think about the artery side. And again, alpha-1 receptors on the arteries are going to cause it to constrict. And so resistance to venous return will go up, as does total peripheral resistance. And so do we want to show that as a clockwise move or a counterclockwise move? And the problem here is that we don't know how much to move it. We do need to move it in a counterclockwise direction, but notice that works in the opposite direction of the increase in mean systemic filling pressure. So the rule here is never move resistance to venous return so much that it undoes what the resistance to venous return curve or the increase in mean systemic filling pressure already did. And so we're going to draw this somewhat down, but not much. And so what you can see is I moved it very slightly counterclockwise, but not so much that I undid what happened. And so when we increased mean systemic filling pressure, we increased or made a hyper-effective heart. And when we increased total peripheral resistance, the net result mostly is from the increase in PMS and the increase in cardiac function that we and our new intersection point is here. And what we find out is that cardiac output is up relative to the black one here, and that right atrial pressure is reduced relative to the black one here. So that's a quick look at a few interventions that we can think about. And with other interventions, we just go through the same questions in a very similar fashion.
So we need to finish up with a couple of quick addenda items.
And the first is to look a little bit more closely at the last notation that I made for you on resistance to venous return. And the issue is, if you increase mean systemic filling pressure and increase resistance to venous return, the question is, you might draw it like you did on the left there that's labeled incorrect. And what you see is the new intersection point would actually be a cardiac output that is below the original cardiac output. And we never do that. It never make such an extreme counterclockwise move when you increase total peripheral resistance that you overcome the simultaneous increase in mean systemic filling pressure. The increase in mean systemic filling pressure is always going to win out. And so we draw it as we did on the right-hand side, where it is moved in a counterclockwise direction, but not so extremely that we cross the regular venous return curve. The second addenda point that we want to make is that when you have a complex intervention, you may have reflex things going on. And so what I recommend for drawing those curves, and maybe the way test questions would be written, to be fair to both the test writer and the test answerer, would always to be considered only the primary intervention unless reflex adjustments were specifically mentioned. So draw the curve for the primary intervention first, and then one by one you can deal with the homeostatic adjustments. So for example, in a myocardial infarction, what would the myocardial infarction itself do? It wouldn't affect the blood vessels, but it would cause a decrease in the cardiac function, like a hypoeffective heart. But then you could go about one by one drawing the subsequent adjustments. So you might then get an increase in sympathetic tone. We looked a little bit about how that might affect things from where you are. And then you might get retention from the fluid, increasing the volume in the container relative to container size. And then finally, you might get some cardiac remodeling or hypertrophy of the healthy cells that would cause the cardiac function curve to go back towards where it started from. And if you draw these one by one, you can sort of follow what the progress of each intervention does, and it makes these curves very, very useful. So that's all I wanted to say about cardiac output and venous return curves. I hope that gives you some insight. And so that's cardiac output and venous return curves in a nutshell.